Then Cauda equina and Conus medullaris syndromes, authors Ryder and Mara from Aventura Hospital and Medical Center. So, in this Cauda equina and Conus medullaris syndrome, they have overlap in, they have this overlap in anatomy and clinical presentation. So, what does they have? They have the overlap in anatomy and clinical presentation. The Cauda equina syndrome, no? So, Cauda equina means it is a group of nerves and nerve roots. So, which are stemming from the distal end of the spinal cord. Cauda equina means it is a group of nerves and nerve roots stemming from the distal end of the spinal cord, levels L1 to L5, and so this contains axons of nerves. It gives both motor and sensory innervation to the legs. So Cauda equina means it is a group of nerves and nerve roots. So they are originating from the distal end of the spinal cord, levels L1 to L5, and this contain axons of nerves that give both motor and sensory innervation to the legs, to the bladder, to the anus, and to the perineum. So bladder, anus, perineum, and motor and sensory innervation to the legs. Cauda equina syndrome results from compression and disruption of the function of these nerves and can be inclusive of the conus medullaris or distal to it, and most often occurs when damage occurs to the L3 to L5 nerve roots. So we will go into the details of the Cauda equina and Conus medullaris syndrome. So these Cauda equina and Conus medullaris, no, they have overlap in the anatomy and clinical presentation. So they have overlap in the anatomy and clinical presentation. So for the purpose of this discussion, they will be grouped and notable differences will be highlighted. So conus medullaris, no, it is the terminal end of the spinal cord. So which is the terminal end of the spinal cord? Conus medullaris. So where is this terminal end of the spinal cord? At the L1 vertebral level in the average adult. So in the average adult, conus medullaris is at the terminal end of the spinal cord at the L1 vertebral level in the average adult. So conus medullaris syndrome, it results when there is compressive damage to the spinal cord from T12 to L2. So where is this level? L1 vertebral level. So conus medullaris results when there is compressive damage to the spinal cord. So when there is a compressive damage to the spinal cord from T12 to L2. So if T12 to L2 spinal cord is damaged, so this results in conus medullaris syndrome. Cauda equina means it is a group of nerves and nerve roots. So from where are they stemming? From the distal end of the spinal cord, typically levels L1 to L5, and this contains axons of nerves. So these are nerves, no, axons of nerves. So they give both motor and sensory innervation. Motor innervation as well as sensory innervation to the legs, bladder, anus, and perineum. Cauda equina syndrome, no, so this results from compression and disruption of the function of these nerves, and this can be inclusive of the conus medullaris, or it can be distal to it, or it could be associated with conus medullaris, and most often occurs when damage occurs to the L3 to L5 nerve roots. So when does this occur? Cauda equina syndrome most often occurs whenever there is a damage to the L3 to L5 nerve roots. So both syndromes, no, so they are neurosurgical emergencies. So what are these syndromes? They are neurosurgical emergencies. So how does they present with? They both present with back pain. Back pain will be there. Okay, so this back pain, no, it will be radiating to the legs. And what else will be there? Motor and sensory dysfunction of the lower extremities will be there. And also there will be bladder and or bowel dysfunction, sexual dysfunction, and saddle anesthesia. So how is the presentation? It presents with back pain. So back pain, no, so that back pain will be radiating to the legs. And what else will be there? The lower extremities, motor and sensory dysfunction of the lower extremities. Then bladder and bowel dysfunction will be there, sexual dysfunction will be there, and saddle anesthesia will be there. So CMS, Conus medullaris and Cauda equina, no, they have a high risk of litigation as delay in diagnosis and management can lead to devastating lifelong impairment. So this Conus medullaris and Cauda equina syndrome, no, so they result from compression of the, so from where does this result? So Cauda equina and Conus medullaris syndrome. So this results from compression of the spinal cord. Okay, compression of the spinal cord and nerves or nerve roots arising from L1 to L5 levels. What is happening? So there is compression of the spinal cord and nerves or nerve roots arising from L1 to L5 levels. So the most common cause of compression in 45% of Cauda equina syndrome, it is a herniated lumbar intervertebral disc. Most common causes we have to think of herniated lumbar intervertebral disc. Other causes include any epidural abscess or epidural hematoma, discitis, tumor, either metastatic or a primary CNS cancer, trauma, particularly when there is retropulsion of bone fracture segments, spinal stenosis, and aortic obstruction. So what are the causes? Most common causes, 45% of the cases it is a herniated lumbar intervertebral disc. Other causes include epidural abscess, spinal epidural hematoma, discitis, tumor, either metastatic or a primary CNS cancer, trauma, particularly when there is retropulsion of bone fracture segments, spinal stenosis, and aortic obstruction. And rare reported cases exist in which Cauda equina syndrome was associated with chiropractic manipulation, placement of interspinous devices, and thrombosis of the inferior vena cava. So in rare reported cases, what will happen? Cauda equina syndrome, no, so this was associated with chiropractic manipulation, placement of interspinous devices, and thrombosis of the inferior vena cava. Cauda equina syndrome and Conus medullaris syndrome, so they are rare. Estimated prevalence of 1 in 30,000 to 1 lakh people per year. So estimates of annual incidence are between 1.5 to 3.4 per million people. And it occurs in 3% of all disc herniations. So this Cauda equina and Conus medullaris are most common in young men. These are most common in young men because this population group more likely to experience compressive thoracolumbar trauma. So Cauda equina and Conus medullaris, no, they are most common in young men because they are more likely to experience compressive thoracolumbar trauma. And a thorough history is necessary with detailed questions regarding any recent fall, any trauma or injuries, any use of anticoagulation. So, because even the epidural hematoma, no, so spinal epidural hematoma, so this is also known to cause this conus medullaris and cauda equina. And any spinal instrumentation, IV drug use, malignancy, chiropractic manipulations, and constitutional symptoms like fever or chills, so all the history should be taken. So patients, no, they can present with back pain and sciatica. So in 97% of the patients, no, they'll have the back pain and sciatica. Patient will also have the weakness and changes in sensation in the lower extremities. So lower extremities, there will be a weakness and changes in sensation. So bladder dysfunction, okay. Disruption of autonomic fibers result in either retention or incontinence in up to 92% of the patients. So bladder dysfunction will be there, bowel dysfunction will be there. Here also retention or incontinence in up to 72% of the patients. Saddle anesthesia, or we can say it as decreased sensation in the perineum in 93% of the patients. And sexual dysfunction, impotence in men. So, what are the symptoms? Back pain and sciatica in 97%, weakness and changes in sensation in the lower extremities, bladder dysfunction, bowel dysfunction, so both retention or incontinence, 92% bladder, saddle anesthesia, decreased sensation in the perineum, 93%, bowel dysfunction, retention or incontinence in up to 72% of patients, and sexual dysfunction, impotence in men. The above symptoms above, when presenting in isolation or neither specific nor sensitive for cauda equina or conus medullaris syndrome. However, several of the signs and symptoms mentioned above, taken as a constellation, should raise the clinical suspicion. And these symptoms, no, so they also lack a significant positive predictive value for the syndromes, especially early on. The onset of, see, first is onset of perineal anesthesia, okay. So perineal anesthesia associated with bladder dysfunction, so this is typical of the start of cauda equina syndrome. First patient, okay, perineal anesthesia is there, bladder dysfunction is there, perineal anesthesia, bladder dysfunction. And at the time, the clock starts on diagnosis and management. It is important also to note that the painless urinary retention, okay, bladder will be distant here, okay. So this painless urinary retention, so this has the greatest predictive value. Urinary retention will be there, but it is painless. It's a standalone symptom, but the thing is, it's unfortunately indicative of late, often irreversible conus medullaris or cauda equina syndrome. So first, when should we suspect? Perineal anesthesia and bladder dysfunction. So this is typical of the start of cauda equina syndrome. And once clinical suspicion is established based on history, a thorough neurological examination is paramount. So findings to watch for include motor or sensory deficits in the legs, okay. So these are usually bilateral, but these can also be unilateral and asymmetrical, particularly in cases with an incomplete injury. Lower motor neuron signs will be there, areflexia, hypotonia, atrophy in cases of chronic cord compression. Okay, areflexia, hypotonia, and atrophy. Saddle anesthesia will be there. Absent or decreased rectal tone. If the tone of the rectum, no, if we examine the tone, it will be absent or decreased. Absent or decreased bulbocavernous reflex. Okay, absent or decreased bulbocavernous reflex. Palpable bladder will be there, indicating urinary retention. So it is also important to note that in cases of isolated conus medullaris syndrome, so deficits of the lower extremities are more often bilateral and symmetric. Isolated conus medullaris syndrome, no, so deficits of the lower extremities are bilateral and symmetric, and upper motor neuron signs can be present such as spasticity and hyperreflexia. The gold standard method is urgent MRI with sagittal and axial T1 and T2 sequences, and there has not been a specific time frame established for door to MRI time, but early MRI and neurosurgical or orthopedic consultation is imperative. So an ideal goal for MRI is 1 hour from the patient presentation. Ideal goal for MRI is 1 hour from the patient presentation. So who have contraindications to MRI, no, such as those with metal implants? A CT myelogram is a viable option. So whoever has got the contraindications to MRI, CT myelogram is a viable option. So this imaging modality has limited utility as it requires ingesting contrast through a spinal tap to visualize the spinal cord and its associated structures. CT myelogram is limited utility. Why? Because it requires contrast through a spinal tap to visualize the spinal cord, and a bladder scan checking for post-void residual volume should be obtained to evaluate for urinary retention. Okay, so to evaluate for urinary retention, what should be done? A bladder scan. And prompt neurosurgical or orthopedic consultation is necessary in cases of Cauda equina and Conus medullaris, as treatment is surgical decompression via laminectomy with or without subsequent discectomy or via the sequestrectomy. Differential diagnosis include spinal cord infarct, HIV myelopathy, transverse myelitis, multiple sclerosis, syringomyelia, and spinal arteriovenous malformation. And so early intervention by surgical decompression, no, conus medullaris is associated with a better prognosis, particularly when surgery occurs within 48 hours of the initial presentation. So when surgery occurs within 48 hours, it has got a better prognosis. The longer the compression, the worse will be the structural and functional impairment and poorer prognosis. And if there is a presence of bladder dysfunction prior to surgery, no, it is linked to poorer outcomes. And